Hello everyone and welcome to another warm-up. Let's get going. Which muscles and nerves are derived from the first branchial arch? So the first arch is the M's and the T's, which makes it a little bit easier to remember that the muscles of mastication and the mylohyoid muscle comes from that first arch. Also with the T here, remember the tensor tympani and the tensor villi palatini. And then for the nerves, again, remember the M's and T's for the maxillary and mandibular division of the trigeminal nerve. Next question. Which amino acids are found in large concentrations in elastin? So in elastin, you're going to find glycine and proline. Next, what is the mechanism of action of adenosine as an antiarrhythmic? So adenosine increases the outward potassium current, causing hyperpolarization of cells and decreasing intracellular calcium, so it basically stops the heart transiently. All right, that's it for the warm-up. Let's get to that lecture now.
This is the first video in the immunology section, and I'm sure some of you are dreading this. But immunology is very, very high yield for step 1. Immunology is very detail-oriented, so there are a lot of little things they can ask about, and it can be difficult for students to learn these details. So don't overlook immunology. I'm going to try to focus on just the details you need to know for step 1. You really don't need to go outside of these lectures and your step 1 review book to know your immunology for step 1. We're going to cover everything that's high yield. So in this first immunology video, we're going to talk about the basics of the immune system and some anatomy and some histology and some conceptual stuff. There are two big categories of organs that can make up your immune system: primary lymphoid organs and secondary lymphoid organs. The primary lymphoid organs are the bone marrow and the thymus. Now, you may not think of your bone marrow as an immune system organ, but that's where all of the cells in the immune system come from: T cells, B cells, and macrophages, and then they have to travel to other sites and mature. For example, the T lymphocytes mature in the thymus, which, again, is another one of the primary lymphoid organs. But that's T as in T lymphocyte, or T cell, and that's also for thymus. Then, the secondary lymphoid organs are just as important as the primary lymphoid organs. These include the spleen, the lymph nodes, and the mucosa-associated lymphoid tissue, or MALT. We're going to cover the spleen in another video, but let's take a look at the lymph nodes. Lots of immune cells hang in the lymph nodes until they are needed. Unlike the GI system or the respiratory system, which are confined to very specific parts of the body, the immune system has to be everywhere, so that whenever there's a breach of the body's defenses, immune cells can get there in a hurry. So lymph nodes are found throughout the body, but they tend to be concentrated in areas that are near openings to the outside world, such as the neck, to be close to the mouth and the nose. About half of the 600 lymph nodes found in your head and in your neck. There are also lymph nodes clustered in the mediastinum, because obviously things get into the lower respiratory tract and the lungs. There are inguinal lymph nodes clustered around the groin, because it's close to the genitals. And there are lymph nodes in the axilla, which drain the breast, because the nipple is a potential entry point for pathogens. In general, the histology of lymph nodes is not terribly high yield for step 1, but I do want to talk about it for a moment, because there are a few important points, and it helps us to understand the interconnectedness of the immune cells. It's fair game for step 1, but I don't want you to get too bogged down in these. So, what exactly do lymph nodes do? Well, macrophages hang out in the lymph nodes and filter and clean the lymphatic fluid, which is essentially the acellular part of the blood, the serum. So macrophages are essentially filtering and cleaning the blood. Lymph nodes also house lots of lymphocytes, B cells and T cells. This is the site of B and T cell activation, proliferation, and differentiation. And it's the important site where the plasma cells synthesize antibodies that are going to enter our circulation. One thing that's worth knowing is where you might find these particular cell types within the lymph node. This is a drawing of a lymph node. The green vessels coming in are the lymphatic vessels, the afferent lymphatics. Lymph nodes usually have lots of afferents. This is where lymph is collected. And the blue one is the efferent lymphatic, and that's where the collected lymph is exiting the node. Then the node itself is this multicolored thing. The outer zone of the lymph node is the cortex, which we've got colored light blue. The innermost part is the medulla, which is dark blue. And then the zone sandwiched between the cortex and the medulla is called the pericortex. And the cortex, you have areas called follicles, which are just regions where there are lots of lymphocytes packed tightly together, specifically B lymphocytes. This is the site of B cell localization and proliferation. So where do you find T cells in the lymph node? Right next to the follicles in the pericortex. The pericortex also contains venules, which is how B cells and T cells get to the lymph node. And then another very important point is that if there's a viral infection and your body is proliferating T cells in order to attack the virus-infected cells, the pericortex is going to become enlarged. In other words, during a massive cellular immune response, the pericortex becomes enlarged. It makes sense, right? If you have a virus infection, you need to have the T cells to counteract the virus, and that area houses the T cells, which is the pericortex, so it needs to expand. In contrast, the pericortex is not well developed in patients with DiGeorge syndrome because you don't have mature T cells in DiGeorge syndrome as you don't have a thymus to mature them. So patients with DiGeorge are not going to have highly developed pericortex. Going back to our drawing, what kinds of cells do we find in the medulla of the lymph nodes? The medulla has little stacks or cords of cells called medullary cords. These cords are made up of B cells and also plasma cells, which is what I want you to remember. The plasma cells are fully mature, fully differentiated B cells that have just become little antibody factories. So plasma cells in the medullary cords. And the spaces between the cords are called the medullary sinuses, which is where you find the macrophages. So remember, M for medulla and M for macrophages. Another type of secondary lymphoid tissue I want to mention is mucosa-associated lymphoid tissue, or MALT. This is lymphoid tissue that is found in the mucosa of the GI tract, the respiratory tract, and so on. For example, in the lamina propria of the intestines, there are numerous lymphoid follicles, which are sometimes called GALT, or gut-associated lymphoid tissue. Up to 70% of your immune system tissue lies in that GI tract. One type of GALT is found exclusively in the ileum. These are called Peyer's patches. Peyer's patches are unencapsulated lymphoid tissue found mainly in the lamina propria of the ileum and also extending into the submucosa. So this unencapsulated lymphoid tissue is not like lymph nodes that have a capsule surrounding them. And these Peyer patches are only found in the ileum, and that's how you can tell the ileum from the jejunum, microscopically. Here's an image of a Peyer's patch. You can see all of these lymphocytes packed in here in the mucosa, but there's no capsule. Then, overlying the Peyer's patch, you have a specialized flattened epithelium called follicle-associated epithelium. So instead of the usual columnar epithelium with goblet cells and tons of microvilli to increase absorption capacity, these follicle-associated epithelial cells are flattened out. And then, interspersed here and there among these flattened epithelial cells are M cells, or microfold cells. These M cells are able to take up antigens from the lumen of the gut and then transcytose the antigens to the other side of the cell. So they bring antigens from the luminal side of the cell to the basal side, where they have a deep pocket-like structure, which is sort of like a docking station for cells, like dendritic cells. B cells, T cells, macrophages, all of these immune system cells that need to know what's shaking in the GI tract. This is how the immune system finds out what kind of antigens are present for the gut that it needs to start preparing for. And then deep in the center of the Peyer's patch, the B cells have been activated and have differentiated into plasma cells to produce tons of IgA. That central portion of the Peyer's patch with all of those plasma cells is called the germinal center. Now let's talk about lymphatic drainage. The lymph fluid drains the lymph nodes where it's cleaned up before going back into circulation. So let's talk about which lymph nodes, specifically parts of the body, drain to. This is a 4-star topic. Pretty much everybody has at least one question about lymphatic drainage on their test. It's usually disguised as a question about a cancer patient with metastasis to a regional lymph node, and then they ask, where is the lymph node region to which this particular cancer might metastasize? So make sure you know these. So here's our buddy Dr. Lewis, and let's take a look at lymphatic drainage, starting with the extremities. The arm and lateral breast cancers are going to metastasize to the axillary nodes. This is why when we do our clinical breast exams, we palpate the axilla very carefully to make sure there's no axillary lymphadenopathy that may indicate breast cancer. And then going to the lower extremity. The calf and dorsolateral portions of the foot drain to the popliteal region. So if you have a foot infection, you might see an enlargement of your popliteal lymph nodes. Make sure you know that. And then the thighs, they drain to the superficial inguinal nodes. If you have an infection in the thigh, then you're going to have some superficial inguinal lymphadenopathy. We'll come back to the superficial inguinal nodes here in a second. Let's look at the lymphatic drainage of the GI tract, which is a little bit trickier. The stomach and the upper duodenum drain to the celiac nodes. The lower duodenum, jejunum, and ileum drain to the superior mesenteric nodes. So it kind of matches the blood supply. The celiac trunk supplies the stomach, and the SMA supplies most of the small intestines. And then the proximal 2/3 of the colon, from the cecum to the splenic flexure, drain to the superior mesenteric nodes as well. When you get to the distal third of the colon, the descending colon and the sigmoid colon, and the upper part of the rectum, all of that drains to the inferior mesenteric nodes. The lower rectum, the anal canal and above the pectinate line, drains to the internal iliac nodes, along with the urinary bladder, the cervix, and the prostate. Below the pectinate line, there's a transition to squamous epithelium, ectodermal tissue, and this region below the pectinate line drains to the superficial inguinal nodes. So everything that's superficial to the perineum is going to go to the superficial inguinal lymph nodes. But the testes are going to drain to the para-aortic lymph node. Make sure you know that distinction. The testes are embryologically not a superficial structure. They descend from within the body cavity. So the lymphatic flow goes back into the body cavity to the para-aortic lymph nodes, which is where the testes come from. That's definitely high yield to know. But the scrotum, and in women the vulva, are superficial structures. And where do we say those superficial structures drain to? The superficial inguinal nodes. Make sure you know that the right arm and the right half of the head drain to the right lymphatic duct. So if there's an obstruction in the right lymphatic duct, maybe because of a cancer, you might see some non-pitting edema in those regions. And then there's the rest of the body, and it ultimately drains to the thoracic duct. And where does the thoracic duct empty into circulation? At the junction of the left subclavian and the internal jugular vein. The junction of the left subclavian vein and internal jugular vein is where the thoracic duct returns lymph back to circulation. Just as we divided the organs of the immune system into primary lymph organs and secondary lymphoid organs, we can talk about the functions of the immune system into innate immunity and adaptive immunity. The innate immune system is fairly primitive. It's nonspecific. It includes cells like macrophages that pretty much attack any foreign invader. And that's what I mean by nonspecific. We don't have some macrophages that only attack Salmonella and some that only attack MRSA. Macrophages go attack any foreign pathogen. And they are nonspecific and indiscriminate. The innate immune system also responds fairly rapidly. Because it's nonspecific, you don't have to ramp up and activate lymphocytes and produce a bunch of antibodies. That takes time. So the innate immune system responds rapidly. The innate immune system also has no memory. We'll talk more about memory cells and the importance of immune system memory later on, but the reason that vaccination works is that you're sort of teaching the immune system what measles virus or the chicken pox or meningococcus looks like, so that if you come in contact with those pathogens later on, the immune system will remember that and attack and prevent infection. So again, the innate immune system has no memory. So the memory part of the immune system involves the adaptive immune system. These cell types that we're talking about with the innate immune system include macrophages, as I mentioned, which are types of phagocytes that engulf the pathogens and then digest them. Another type of innate immune system cell are the dendritic cells. Dendritic cells are phagocytes that are professional antigen-presenting cells, which means they phagocytose the pathogens, digest them, and then put the little antigenic piece of that pathogen on the outside of the dendritic cell to present that antigen to the helper T cells. The helper T cells then become activated. It's almost like they're flagging down the T cells by waving a banner and shouting, "Hello, I found something you need to attack." But we're going to cover the antigen presentation in detail in the next video. You have neutrophils, which are another type of phagocyte. And also the mast cells, eosinophils and basophils, which are responsible for secreting histamine and cytokines and signaling chemicals that attract other cells to mediate inflammation. You can think of these as being nonspecific signals, and the inflammation is certainly a messy, indiscriminate, nonspecific process. And if you've ever had an allergic reaction, you know that mast cells and basophils can degranulate rapidly and whip up a little histamine. So again, the innate immune system responds rapidly. Another component of the innate immune system are the natural killer cells, or NK cells, which is interesting because NK cells are actually a type of lymphocyte, and otherwise the lymphocytes are a part of the adaptive immune system. But NK cells are considered a part of the innate immune system. The innate immune system also includes complement proteins, which obviously aren't a cell type, but complement proteins can be a bit indiscriminate. We'll talk about complements in another video. And the last part of the innate immune system is just the skin and other barriers, like gut wall mucosa, which are like a wall that try to keep everything out. Very nonspecific and indiscriminate. Then to contrast the innate immune system with the adaptive immune system. The adaptive immune system is less primitive and more advanced. Instead of being non-specific, the adaptive immune system is very specific. It's like the immune system 2.0. You have very specific receptors on the T cells and very specific antibodies on the B cells that allow these cells to respond only to specific antigens. So there's some genetic variation and recombination that allows the receptors and antibodies to become very, very specific to the antigen epitopes they bind. We'll look at that in another video. The adaptive immune system also generates memory, so that you don't get measles or chickenpox every time it starts going around. And as we've said, the adaptive immune system takes a bit longer to get activated the first time as it sees a pathogen, although the second time around, when the memory kicks in, it responds much more quickly. The adaptive immune system consists of T lymphocytes and B lymphocytes, and also the circulating antibodies, which are produced by plasma cells. In what cell type do we say the plasma cells are derived from? From B cells. Plasma cells are just B lymphocytes that have matured into antibody factories. All right, let's go ahead and go through your end of session quiz. Let's get started. First question. To which lymph nodes do the sigmoid colon and rectum drain? The sigmoid colon and upper part of the rectum drains to the inferior mesenteric nodes. The portion of the lower rectum that's above the pectinate line drains to the internal iliac nodes. And then the distal to the pectinate line, the anal canal drains to the superficial inguinal nodes. Next, in what parts of the lymph node would B cells and T cells be located? B cells are found in the follicles of the cortex. T cells are found in the paracortex. Last question. Where would you find Peyer's patches? They're found in the ileum, specifically in the lamina propria and the submucosa of the ileum. That's it for Immunology 1. In the next video, we're going to talk about antigen presentation. I'll see you then.